Testing. Test, 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 1, 2. Test, test. Is it too high, too low, or is it good? Testing. You good right there? Okay.
Okay, we're going to get started now. The vendors at the table, if you're comfortable, you're fine. If you want to join over in the seats, you're welcome. Good morning to everyone. I'd like to welcome everyone here. My name is Debrina Campbell. I'm a public health nurse with DPH over at Spa 6, the MLK building, under supervision of Ms. Deanna Bresler Montgomery and my regional office manager is, my regional director is Dr. King. Sorry, Dr. King. On behalf of Los Angeles County Department of Public Health and the Infant and Maternal Mortality Prevention Initiative, South LA, South Bay Community Action Team, that's a lot. SPA 6 DPH Regional Health Office, Charles Drew University Maternal Health Center of Excellence, Kindred Space LA Birthing Center, Black Women for Wellness, and California Black Women's Health Project, we are honored to have you present where we will be honoring, celebrating, and elevating midwifery and public health. This event, a community-centered celebration aimed to uplift midwifery as an evidence-based model of care that improves birth outcomes and centers the need for equitable, culturally competent care. Here in the room, we have midwives, expecting families, birthing people, healthcare professionals, and community advocates from across the country. Welcome, and we want you to please be mindful of your phones, and can we please put them either on silent or reduce the ring volume? If you need to use the restroom, restrooms are in the front of the building where you came in. I will now introduce Dr. Batra. Dr. Batra joined the Los Angeles County Department of Public Health in 2022 and served Deputy Director of the department's Health Promotions Bureau. Prior to joining the Department of Public Health, she worked for several years in Medi-Cal managed care leadership for the Inland Empire Health Plan. She has a background in health services research and is an adjunct physician policy research with the RAND Corporation. Dr. Batra, an OBGYN, still sees patients. You can find her in the clinic on Wednesday nights in South Los Angeles at Martin Luther King Jr. Outpatient Center County site. Dr. Batra brings a strong commitment to health and community engagement to all of her work. Please let me introduce to you Dr. Batra.
Good morning. Thank you, Sabrina, for the introduction, and to our SPA 6 Regional Health Office team hosting us in this space. We're really grateful to be here with you all today. And I want to shout out, we have representation from Assemblymember Isaac Bryan's office here today, District 55, so thank you for joining us, for your support. And a huge thanks to our African American Infant Maternal Mortality Prevention Initiative, or AIM initiative team, for organizing today's celebration. So, this time of year, this is me in spring. This time of year brings many reasons to reflect and rejoice, right? We've just honored the contributions of women in Women's History Month in March. We welcome the renewal of spring. We're recognizing a lot of cultural and religious celebrations, and we are celebrating National Public Health Week. So preparing to observe Black Maternal Health Week, which is a critical time to focus on the health, dignity, and well-being of Black women and pregnant people. But as we celebrate National Public Health Week this year, we're going to acknowledge our progress. We also have a lot of ongoing challenges that public health is facing in our current environment. So I want to take a moment to tell you about that and to reassure you about what our department is doing to face these challenges. So as you all know, the work we do in public health is nonpartisan, and it is focused on the well-being of everyone we serve here in LA County. And despite that, our ability to protect residents, to protect our communities, is being threatened by massive proposed budget cuts from the federal government. So 2 weeks ago, our department was notified that more than $45 million in previously awarded grant funds intended to last through July of 2026 were rescinded without notice. These funds are foundational to our public health infrastructure, and thankfully, a federal court granted a temporary restraining order last week, which means that our funding for these programs can continue for the time being. I want you all to be assured as you read these news reports of what has happened and what will come. We will continue to work with our state and local partners, that includes all of you advocating with us, to hold our mission, which is to advance conditions that support optimal health and well-being residents, all residents of LA County, without compromising our values. And so we know that these abrupt cuts to funding and to services will have a real impact on the health and well-being of our communities, and that is true in the health space as well. And so we all know here that the maternal health crisis persists. Black mothers in LA County experience pregnancy-related deaths and complications at a rate that is much higher than that of other groups, and highlights the urgent need for effective interventions. And so we know that actions to address these disparities must be bold, and our investments need to be given. And really, midwifery and birth justice initiatives are core to addressing this problem. So we have evidence that midwifery care, which we're going to talk about today, is a powerful tool, I say this as an OBGYN, for improving maternal and infant outcomes. Midwives offer holistic, evidence-based, and culturally affirming care that supports healthy pregnancies. It reduces unnecessary interventions, fosters positive birth experiences and satisfaction. But despite these benefits, midwifery remains underutilized, and that's really due to a lot of systemic barriers to this service. And so I want to highlight those because I think we're going to talk about that later this morning. So of the 27 birth centers that are currently open in the state of California, only 4 are licensed by the state. And that means that without licensing, birth centers face billing for their services and sustaining this really critical model of care. Midwives in California, especially licensed midwives, are often restricted from practicing to the full extent of their license or expertise. And they have frequently challenging relationships with hospitals, physicians, and health plans. So this makes it incredibly challenging for them to provide the services that they do. And then also we know that there's really high interest in midwifery care among the population we are serving. So surveys of pregnant individuals across the state consistently show that there's really great interest in this model of care, particularly among those with lower income and who have public coverage through Medi-Cal. So it's really frustrating that these very patients who are most interested in midwifery care, in doula services, have most barriers to accessing that care in our current system. And so at Public Health, we are taking proactive steps to uplift and support midwifery care as really a critical component of this care continuum for moms and babies. So all of our programs, the AIM Doula program, our Perinatal Equity Initiative, Black Infant Health, and Home Visitation promote the use of midwifery care, and we try to connect our clients who are interested in midwifery care to all of your services. So I want to give a real shout out to our collaborators in supporting this work. We have Kindred Space, which is one of our speakers today, Black Women for Wellness, Spa 6, and The Abundant, and also California Healthcare Foundation for sponsoring this work as well. And I want to name some individuals who have been like our consistent partners in working to uplift midwifery models of care. Debbie Allen and Kimberly Jordan, who also served as AIM Doula program mentors. Kimberly elected our colleagues for providing the first doula training for our AIM Community Doula program in 2021. Dr. King and her team at Spa 6, our regional office here. Raina Granberry and Sonia Adam of California Black Women's Health Project and Black Women for Wellness, who are steering committee members for AIM since the inception, and then also do really critical work with our state and local policymakers to keep the focus on maternal and infant health and midwifery care as a really leading model. Dr. Randy Desjolais, Dr. Bita Amani, Chanel Bailey, and the whole team at the Charles Drew University Black Maternal Health Center of Excellence. And then again, to all our partners and vendors who are here with us today, birth workers, community organizations who've walked with us, let us walk with them, really, to ensure joyous, safe births throughout LA County. If you're a midwife, a doula, or represent a program supporting pregnant women, can you raise your hand? Look at this. So we really want to thank you and celebrate you today. We really appreciate all your hard work and thank you for your service. So with that, I'm honored to introduce Dr. Brandy Desjolais, who's director of the CDU Black Maternal Health Center of Excellence.
Good morning, everyone. So today I have the pleasure to introduce a really dear friend and colleague, Melissa Franklin. So Dr. Franklin is a public health leader, entrepreneur, system stretcher, and community advocate with over 25 years of experience in organizational development and communication and engagement strategy for both public and public education sectors. In her public health role, she leads the Maternal, Child, and Adolescent Health Division of the Department of Public Health. Dr. Franklin helped launch Los Angeles County African American Infant and Maternal Mortality Prevention Initiative in 2018 as a fellow, which remains one of her program areas today. Through robust community collaboration and the efforts of her team, she has recently stewarded the launch of a medical doula hub, motherboard, the Guaranteed Basic Income Pilot, and a doula program for incarcerated pregnant individuals. She's a South LA resident and a mother of two with her own story of birth trauma, resilience, and joy. And we are so grateful for her leadership, her accountability, and the love ethic that she brings to her work, especially as she shifts to make them more hospitable to community birth workers such as midwives. So please join me in welcoming Dr. Melissa Franklin.
Good morning, or whoop, whoop. I'm a whoop, whoop person, so. Thank you, Dr. Desjolais, for the intro, and Dr. Batra for setting the stage for our interesting times. But, you know, I was made for interesting times, so I don't know about y'all. Anybody here made for interesting times? I'm made for interesting times and unafraid. I want to thank our director and birth equity unit chief, Adwa Jones. Where is she? Running about 50 laps. It's all good. Thank you, AJ team's work, along with the entire AIM team. AIM founders, many are whom in this room. It's so amazing just to look out, see folks that they've been there from jump. When it wasn't popular, when there was no funding, when it was just being tired of seeing moms and babies perish. And our systems not rise to the opportunity, to the dreams that we have for our births, right? Thank you also to those who are not here, but definitely were a part of that work, including Helen O'Connor, who is part of the trifecta, just leaning in and stretching our systems. Feels like at times that it's coming from all sides. And when it does, I believe that we lean back. We lean back and show each other and prepare to engage. And so we are excited about the work that AIM Prevention Initiative has been doing over the past 6 years, but even more appreciative of the partnerships that we've been able to foster through our collection of weeks, through the solidarity that has really blossomed in this work. As a collective body and activated village, we have worked to ensure that Black mothers, birthing people are supported and celebrated, not just kind of barely surviving, barely making during their pregnancy and birthing journey. We further work to integrate dads, partners, their infants and children in the provision of services and resources. Since we began AIM in 2018, we have worked closely with midwives, clinicians, and other birth workers to support Black women's autonomy in birthing and ensure they are aware of the rights and options available to them during their pregnancy and postpartum journey. We always say joyous and healthy births, because as I said, just making it, don't let it, right? It's about joy and well-being and health and not just survival. We further understand the challenges that our families as well as face in being able to cover services outside of the hospital setting. So as we continue to see the closure of many maternity wards throughout California, we know there is a need to support local birthing centers, midwives, and midwives that provide reproductive health care in our communities. Places like, and they were mentioned before, Space LA, Mind Body Birth, Tribe Midwifery, Jasiri Midwifery, and maternity homes like those being opened by our colleagues at Charles Drew Black Maternal Health Center of Excellence. Our goal is to ensure that policy SB 65 that are supported and those presented like AB 55 are all made aware of and see how our systems can support and our communities can benefit from them. Finally, I did want to share about something that's upcoming in our work in AIM. Who can tell me how many, and no ringers, how many Black births are in LA County each year approximately? Good guesses. 8,000. There are 8,000 Black births approximately in LA County, give or take a couple of hundred each year. I think 8,000 is reachable, don't you think? Like, that's an impactable number. I think 1,000 Black folk in my family alone in LA, right? Like, that is something that's reachable, that we can connect with, and is definitely possible, and that's going to be a big part of our focus next year as we continue to engage systems and partners to touch the lives of 8,000 Black pregnancies, right? To ensure that they are supported, that they're abundant, that they are joyful, and definitely, right? That well-being is at the center. So I look forward to seeing y'all and you folks. That's not even a Beyonce concert. I mean, that's doable, 8,000. We are grateful to you, our community, and ask that you stay connected through our community action teams, Motherhood Engagement Program, Community Doula Program, Abundant Birth Project, Black Infant Health Program, Medi-Cal Doula Hub, also our Black Infants and Families website, IG and Facebook, and our numerous maternal, child, and adolescent health programs. Shout out to NFP in the house. Woo, woo. Thank you. We are in these streets supporting healthy and joyous births and leaning in, whether it's challenging, supported, funded, or just an extreme honor to be here as someone who did not enjoy an amazing birth experience, to be able to advocate that for my sisters in this work. So thank you all. And I think we have a video coming up next. Video, right? Coming up next.
themselves go from being places where only the great four went to places of science. The one place in which we persist is in the Deep South. Because white kids might not be willing to attend births of black women, and hospitals themselves will say, and so women couldn't go to those.
Basically every state developed a regulation process and began licensing. But one of the downsides to that was this demonization of the midwife, especially what they called the granny midwife. Especially in an era when white supremacy was very prevalent, when, court laws in the South are controlling how black people can be educated and women here. If you say that every midwife is required to complete these documents on every mother that's registered, her literacy is limited, and then that's a barrier. You may have someone who had delivered every baby in a county, but all of a sudden she couldn't adhere to those rules or wouldn't adhere to those rules. She's now, essentially criminalized, or at least, a renegade. Part of what led to the elimination of midwives was just by stereotyping people as ignorant, dirty, illiterate. The fact that this workforce was mostly black women, and that those that were immigrants, this really was about race and class. Over time, nursing midwifery became recognized as a profession. Nurse midwives are being formally educated in a university setting, where most black women, it was out of their reach. I entered in 1980, it was overwhelming, but I always knew that I wanted to go to my own hospital. I was going to be the best midwife that I possibly could, and that's exactly where I wanted to be. The struggle was just to prove that we were a legitimate and we had a right to exist and be. Over time, however, that changed. We became more integrated into the department. Midwives show decreased cesarean rates, lower preterm birth rates, higher breastfeeding, higher vomiting, just higher any parameter that one would ascribe to better outcomes. Integration of midwives contributes to that.
There are studies that compare what happens when you have low-risk cases dealt with obstetricians and low-risk cases dealt with by midwives, and generally midwives do better. It's part of a system where there'll be referral of higher-risk cases to obstetricians. But, great, that's exactly how it should be. For high-risk, you absolutely want to have the highest trained obstetrician possible. The fact of the matter is, for most women, they don't need that. The challenge in the United States is we built up the system around obstetrics, and systems don't change very easily and without much pain.
Relationship. It's the relationship that's the most important thing, and that's what the women got. They got a relationship that was not effective. It was genuine, and they knew it.
If we're going to try to address the problem of racial disparities in outcomes, midwifery is, in one sense, really prepared to do that because of the nature of the care they provide. On the other hand, midwifery is an overwhelmingly white profession at the moment. And so there's a dire need to diversify the profession itself if it reach those folks who most need it.
Before we were black midwives, we were black women, and we have the same living daily experiences that these women have. That's what black midwifery brings, and that's what's different from midwifery in general. I decided to create a midwifery practice in Memphis because I thought
give a resounding applause to all of the midwives, the granny midwives, those who have served, the birth workers, that's doulas, including yourself, the advocates, the policymakers, the mamas, the daddies, the babies, all of our physicians, thank you. Yeah, I'm like, I'm stuck, huh? You can turn this off. Shin may have to help us.
There you go.
Okay. All right, thanks. So yeah, we want to honor everyone who's here. I want to thank you all for joining us. My name is Audra Jones. I am the Birth Equity Unit Chief with our Maternal, Child, and Adolescent Health Programs. And yes, thank you, thank you. And the AIM Prevention Initiative Director. So I'm excited to be here with you noon. I'm excited to always be in community with you all. I want to thank my directors, Dr. Priya Batra, our Health Promotion Bureau Chief, Dr. Melissa Franklin, yes, the trifecta and partner. I always talk trifecta to Tamara in the back. But it's always good to come together to Jan Robinson Flint here, who's been my compadre. She don't want me to kiss, but it's been a mighty long time. We've been doing this work. To Dr. Brandy Desjardins, CDU for partner, and Chanel, thank you so much for all that you've done, and her team, the entire CDU team. The AIM team, Debrina, thank you so much, Debrina. Debrina, our public health nurse, who really gets out here for SPA 6 and make sure all of this is happening. Ariana, our team, I saw the briefing, Ariana, so our director's briefing went out. Thank you, thank you, thank you. Talk about AIM for Department of Public Health. Caroline's representing SPA 8. I see our AIM doulas here. And I want to thank each and every one of you, our vendors and colleagues that are really here to support this effort. It's critical. I've met Brother Bruce McIntyre. I've seen him and talked to him just briefly, but nobody wants to join the club that he had to join, of fathers who had to bury their partners or their wives as a result of preventable maternal mortalities and mortalities. And so that's why we're here today. We want to talk about what it is we're doing, because just like him, after she had to create Save a Rose Foundation in honor of Amber. And then you also have Charles Johnson, who had to create For Cure for Moms as a hair loss. And then even for Bruce, he's been fighting. I don't know if anything has changed the past 2 years, but I know up until for the first 3 years of his son's life, he was fighting for his paternity status in New York, which is challenging. And we did that here in LA for Nigel Robertson, April Valentine's partner. And so that is not what we want to have to do. We want to support and celebrate and elevate. And so as a result, I'm going to call these ladies up one by one as I share with you who they are and have this illustrious panel of midwives here who've been here in LA County. Give them a round of applause, doing the work to ensure moms and birthing persons have a safe place, that dads are supported and elevated and brought into the space, and partners as well. So I'm going to call up first Kimberly Durton. Kimberly is a midwife certified, a CPM and an IBCLC. I met her when she was a doula, but Kimberly is an international board certified lactation consultant, childbirth educator, and trainer. She trained me. A mother of 6 and grandmother of 5, she credits her children as the greatest teachers with 29 years of experience supporting families of New York City, DC, and LA. Kimberly has provided lactation care, postpartum support, childbirth education, labor assistance, and mentorship for birth workers. She co-founded Kindred Space LA with Allegra, South LA's only Black-owned birth center and a hub for midwifery, doula training, lactation consulting, and community support. Her nonprofit, the Birthing People Foundation, offers accessible training and certification in perinatal professions for people of color, aiming to improve birth outcomes and restore ancestral wellness traditions. Kimberly lives in South LA with her partner Mike and their 2 youngest children. Her oldest children live nearby and one resides in the DC metro area. Y'all meet Kimberly Durton. Next up, we have Allegra Hill. She's a licensed midwife, certified professional midwife, and lactation consultant. She began her work supporting people in birth as a doula in 2011. In 2014, she graduated from the National Midwifery Institute and became a CPM and a licensed midwife in 2015. In 2015, she became an international board certified consultant. She is also the co-founder and co-owner of Kindred Space LA and the Birthing People Foundation. She has trained and mentored birth doulas since 2013 and has participated in training of birth workers within the Birthing People Foundation. Allegra uses her extensive knowledge and training in nonviolent communication, conflict resolution, early child development, and cultural competency in all her areas of work. It is an honor to support families as they make, grow, birth, and nourish their children with confidence and support. Welcome, Allegra. Thank you. Next up, we have Janelle Moore, who's a licensed midwife and the founder of Jasiri Midwifery. She holds a master's in public health and has worked in sexual and reproductive health and advocacy for years. Prior to midwifery, Janelle dedicated her career to working in HIV research and prevention, specifically among BIPOC and LGBTQI communities. She has worked with HIV pregnant and breastfeeding people in Uganda and the DR Congo, as well as managed HIV research projects in Cambodia and the US. As an LA-based home birth midwife, she provides trauma-informed, culturally competent care from a sex and body positive, gender-affirming framework. In addition to midwifery, Janelle is a faculty instructor at Common Sense Childbirth School of Midwifery. Just heard about Common Sense, where she develops original curriculum and teaches epidemiology and HIV classes. Currently, Janelle provides free group prenatal care for Black families in Long Beach in collaboration with the Birth Workers of Color Collective. Please meet Janelle. Thank you. Last but certainly not least midwife on the panel is Debbie Allen of Tribe Midwifery. Yes, Debbie has nearly 3 decades of experience in doula services, childbirth and midwifery, education, and public health. Debbie is a dedicated midwife and advocate for the Black maternal health spaces. As CEO and CFO of Los Angeles' first Black-owned birth center, the Community Birth Center, she played a pivotal role in expanding access to culturally competent care for Black families. Through her work with Tribe Midwifery and the Wellbeing Alliance, Debbie remains committed to improving birth outcomes in communities most affected by maternal health crisis. She
important piece to how you birth your babies, having full-term babies, and just the quality of your care. So yeah, I concur, we do it better.
Okay, thank you, thank you. So then I'm gonna have someone else answer this next question. Tell us the variations of midwifery care, so or the licensure, so folks have an understanding of why, granny midwives and why everybody cannot still practice midwifery in certain areas that had been, or their ancestors had been. So who wants to take that one on? Traditional life, yep.
I can answer that.
Okay.
So as the alluded to, there was a concerted effort to eradicate midwifery by the American Medical Association and the National Departments of Public Health. But because there wasn't anybody else to actually catch and deliver the babies, there weren't enough doctors to. A stopgap or a solution in the short term was to create the certified nurse midwifery pathway. And so what that means today is that there are 2 types of licensures for midwives. There are certified nurse midwives who are RNs. They're registered nurses first, who then go on after they receive their RN to get a certificate in midwifery, and they are trained specifically in hospital births. They also have the ability, if they choose, to attend births outside of hospital, in a birth center or at home. There's also the CPM. We're all CPMs up here. That's certified professional midwives, and that's entry training where you're not required to be a nurse prior to doing the training. Our scope specifically, though, is out of hospital. meaning birth center or home birth. We will never have hospital privilege. I can say that I chose this path because I'm not interested in attending in the hospital setting. So those are the two distinct types of midwifery licensure in the country, and that also still depends state to state, whether they recognize CPMs and make it possible for them to practice, or it's just CNM based.
Thank you. So I shared even briefly in that film that midwifery care had to improve maternal and infant health outcomes. Can you highlight, share with us some of the areas of the, our key statistics that you'd like to highlight and share with folks of the value of midwifery care?
Yeah, I can.
I know you will.
So midwifery care is preventative care. So when you're meeting with your midwife, are learning about how to care for yourself, learning about where to ask for help for your community. And so all of that, it means that the pregnant person is healthier because they have access to information, they have access to support, and they have a trusted care provider to really ask their questions to. I feel like in the OB model care, there's not very much education. Sometimes people need to learn how to do things differently, and it's nice to have somebody who you trust who can help guide you towards having a full-term pregnancy or towards having the vaginal birth out of hospital or in hospital, depending on what your choice is, to help you plan for how to educate yourself if you want to breastfeed. It's a lot of education, and it takes a lot of time. And so the way that looks is we have, in midwifery care, it is incredibly rare for somebody to have preterm birth. Incredibly rare, which I know in the dominant culture, it's kind of like the thing, like Black and brown people is hard to get full term. That's not what we're seeing because we're taking the time to sit with our clients and educate them and guide them as early as really they can come in the pregnancy. Midwives also do preconception work. You could meet to learn about lifestyle changes that you want to implement before becoming pregnant and then throughout the course of your pregnancy and then into your postpartum. Not to say that preterm birth doesn't happen, but I would say it might be 24% lower is what Debbie's telling me. Which I see, it's like, when I went into birth, I said, oh my goodness, this is something we really have to look out for, but then just doing the traditional model of care we're really not having to look out for that so much because it's kind of like baked in. Your chance of having a vaginal birth instead of a C-section goes way up. Our rates vary, but it's about 10% usually for midwives and people needing to have a C-section, whereas in most hospitals, closer to 35%. The risk of something bad happening during the birth, like the risk of death or like needing more medical intervention, that greatly goes up with a cesarean birth. So if we can increase the number of people that are having access to normal physiological birth, we will also see the rate of death go way down. I've seen that 80% of death happening in this country would go away if people had access to midwifery care. So, and really it's support and education that has a positive outcome on the birth and the postpartum and really the whole of the family moving forward.
Thank you. Were you going to say something, Kim?
I was going to say that another thing that we often don't think about, because we can't cookie cut like true midwifery care into this medical model. So a couple of things. One, so like they come into midwifery care and they tell their friends and family, well, I know the traditional route is to go to the hospital with the OB, but I'm going to try something different. First of all, let's fix our mouths to say that what is happening in our medical system is mainstream medicine. It is not traditional. Midwifery is traditional. Midwifery is ancestral. We are the traditional model. So let's flip it around and use our words carefully because they carry a lot of power. And it also shows you how brainwashed we are into seeing hospital birth, which has only been around for maybe 100 years, probably less for Black people. That's one thing. The other thing is that the time and the access that we have, the access that our clients have to us is completely different from the medical model. I mean, if anybody here has a physician, call him on the phone right now, see him if he answers. Send him a text. You know, you could have a raging headache, you could be bleeding out. Call your doctor and see what happens. You're going to get a phone tree, you're going to get the runaround because it's a huge system caring for a lot of people. And traditionally, we're not caring for, Allegra and I are not caring for thousands of babies a month or even a year, right? That said, also, the time we spend with our clients is a lot longer. Each visit is approximately an hour. When we do our care, folks are hanging out with us for like 2 hours. They're getting the education, they're getting the community, they're getting, thank you, Dr. Desjolais, for helping us support our group care model. And so that's another piece that I think you have to kind of really know where the differences are in time. And it also, quickly, I'll say, it relates to this insurance reimbursement idea and this licensing thing. And I can talk more about that later, but it does not fit as easily into that model.
Yeah. I was saying, you're getting ahead of me.
I know, sorry.
Janelle?
I would just like to add too, and I just read this last night as I was preparing, that just this last October, the World Health Organization put out a position paper, and they had their statisticians do some mathematical modeling, which was basically to predict what the impact of universal access to midwifery care would be. And it showed that maternal and infant deaths would decrease by 60% globally. Wow. With universal access to midwifery care, which translates to 4.3 million lives saved by the year 2035, and that's per year.
Wow.
So within 10 years, we get to 4.3 million lives saved per year, which is a 60% decrease in maternal and infant death if folks had universal access to midwifery care, despite where they actually plan to give birth, right? Because our care is also this prenatal course and preconception, as Allegra said.
Thank you for sharing that. And that takes me to the next question is, so when someone comes, before we get into access and Medi-Cal and underutilization of midwifery care, let's talk about what someone would experience if they came to you, what services you would offer, what they can expect to get. And it sounds like what Kim has is a homegrown, well-spent time that folks don't want to leave. They stay for hours in your space. And so
This is true.
I've been there. So just, you guys can go
Audra was one of the ones staying for hours. We're like, Audra, is she pregnant?
I go back. I go back in the room with my laptop and just like, let me see what's going on around here. Let's talk about that. I know, and I'll start with you, Debbie, because I know you were offering a free clinic, and we would put your flyer on the table so folks would know, here's a free clinic, because there was an experience. I was in San Fernando Valley with one of our AIM community action teams, and there was a young mom there, and she was about.
So that's number one. So we get to know your family. I think we kind of this question, but we get to know your family, what your needs are, what your stressors are, where the gaps in you as a person, food diversity, everything that you need that contributes to a healthy pregnancy, because you don't get that in a 5-minute appointment with an OB. So we all get to know our people, and they get to know us. So they tell us things that they wouldn't feel comfortable telling an obstetrician. So when you have care with someone from that perspective, that's automatically a game changer. So I think that just walking into an office where we see you not as a statistic, but as a human being is going to make a huge difference in your care.
Thank you. I was thinking back, and thank you for that. It's true. I do call the one just spoke and the one on the end, and they tend to answer my call all the time. So I just can imagine if I were their client, how frequently they would answer. But they do tend to answer my call. So, and they're busy. I'm like, can you talk? I have just one question. Who wanted to go next? Janelle, you want to share about your services at Jasiri Midwifery?
Sure, yeah. At this point in my practice, I'm focused on group prenatal care for Black families. And so I'm grateful to be fiscally sponsored by the Black Maternal Health Center of Excellence. Thank you, Dr. Desjolais.
Woo!
And so I host group prenatal care sessions in Long Beach. at the Birth Workers of Color collective space. We are there every other Saturday morning. And this is a way for folks to have access to myself as a midwife and receive midwifery care prenatal, even though they're planning to birth in a hospital. Because it's shown that, and it's my belief, and I know it to be true, that we, midwifery, we improve outcomes regardless of location of birth. So this idea and the financial barriers in folks who, for various reasons, plan to birth in a hospital. It could be access, it could be financial, it could be that they're high-risk pregnancy. Regardless of still having access to midwifery care prenatally improves outcomes. And so that's the work that I'm focusing now is group prenatal care.
What's group prenatal care? What's group prenatal care?
Group prenatal care.
Does anybody know what group prenatal care is there?
Yeah, I'm sorry to assume everyone knew what it was.
No, it's
Let
cool.
me explain. So, said it's for folks who are planning to birth in a hospital, but want midwifery care prenatally. And so we meet as a group. My group is Black birthing people only, and it's 2 hours that we meet, and we discuss whatever topics come up and whatever folks want to discuss. Of course, as a midwife, I want to touch on nutrition, and I want to touch on different, topics. Meet in the group setting, we discuss as a group, and people are able to share their experiences, their own wisdom, and then one by one, I take the individual pregnant person back to a private area and actually do the clinical assessment, right? Listening to fetal heart tones, measuring for fetal growth, and also discussing with the clients anything personal that they don't want to discuss in the group setting. My clients typically bring me their lab work that's been done by their doctor or request that I have access to that so that I can actually go over their lab work with them, because oftentimes I've found that folks' blood is drawn or their urine's taken and they don't really know what the results were, or they're told, oh, here's some baby aspirin, or you need to do this further diagnostic testing, but it's not really explained to them why. And so with access to their labs, even though I'm not the person that drew them, I'm able to explain to them more in depth and have that one-on-one time about, well, this is what, hemoglobin, and this is where your iron is, and this is why it's important to focus, whether it's supplementation or through diet. So that's group prenatal care. It's a group setting, but there's still one-on-one private time.
Thank you. I see.
Yeah,
Yes,
and so Kimberly and I work together at our birth center, Kindred Space LA. We provide home birth and also birth center birth. We have individual care where we meet individually with the clients for 1 hour. We also have a group for people wanting to birth in the center or at home or in the hospital setting. So there's a lot of options for people. If you know that you have a high-risk pregnancy and you need to be in the hospital, you can still have all the benefit and support of midwifery care, the individual model or in the group. The other great thing that the group offer people is community, and that's actually the name of our group, is we call it the Community Love Package. And so people used to be in group all the time in pregnancy for prenatal yoga, and then COVID came, and it was like we forgot that people used to be together to have a shared experience. And so a lot of people are choosing the group care model, not only because it's more cost effective, but also because they have the benefit of community and support from peers.
Right, and I just wanted to add to, we're all designing our group care models, in ways that fit not only the services we're offering, but the community at large. In our group care, we do get funding from BMHCE for our Black mamas. Thank you so much.
Yeah.
But our group care is, and sometimes we get grant funding from other sources, so we can try to help as many people as possible. But group care is for everybody. So we have, and actually our care, although we center Black and brown people, we have plenty of white folks that come to us and adore our care, also feel seen, also feel heard. We have a diverse midwifery staff. One of our midwives is indigenous Japanese. She's from Venezuela. She speaks Spanish. So we're able to really wrap around our community. But one thing that we're forgetting about is the postpartum care, whether it's for individual postpartum care, where we're seeing our clients at least 4 times in the first 6 weeks. But Audra alluding to people not wanting to leave, because we have this group postpartum on Wednesdays, and it used to be like every 2 weeks, right? And we found that we were kind of losing people because of when people gave birth. And so we decided, let's just make it weekly. And Ika actually runs that group, so she can hold all the babies. It's pretty much, she's just in there vibing out, having big oxytocin hits from the babies she gets to hold. But seriously, it meets every week from 1 to 3. But we noticed that, and it's supposed to go up to 8 weeks.
Ika can,
Say what?
Ika can join us. Come on.
Oh, come on,
up.
Ika. And so Ika, so we extended the group postpartum to go up to 8 weeks because we figured that's what we're needing. But people actually don't stop coming. So currently we have someone in that group that I think is like, their baby's like almost 5 months old.
But now it's so cute. They know they're not supposed to be in the group anymore, so they bring food to share. They bring like a piece. One lady ordered pizza. She was like, "Thank you for letting me be in your group." So she fed all of her friends in the group.
Oh, come on, Ika, you want to tell us a little bit about the group? Introduce yourself and then tell us.
Hello, everyone. My name is Aika. I've been so lucky to work with Allegra and Kim and Hiroko. And the postpartum group and prenatal group, we see how much people love it. People sometimes stay way past 8 weeks, and sometimes I tell them, still come, as long as there is enough space. People come, people sometimes bring pizza. They talk about being moms, sleep deprived, their partners. And it's just the community. It's what people need. And even with social media, we're finding so many families. They scroll through Instagram and TikTok, but they're not getting the community they need. And then sometimes we find families months after, they're going to the park together with the other moms and their babies and taking photos. And I don't know, it's just so beautiful to see how we are creating the community we need. And with social media, it can be so amazing, but many people really miss to be in community with each other. And I don't have any kids, I only have a dog, but just seeing how moms support each other and how we need. And I always say that women that don't have children, we should be around women that have children.
Right.
And that way we can create better communities.
Right. Oh, y'all aunties. Our shangazi is a Swahili word for auntie, but we call y'all aunties.
Yeah.
So thank you. Y'all saw how she floated up here, right? I told you, the midwives be floating. I'm like, look at her.
I want to also say that a beautiful thing about the postpartum group and how it has developed, especially for our moms that need more support in some capacity, like maybe it's outside of 6 weeks, or maybe even they're within the 6 weeks, but they're alone and they're really isolated and their mental health is struggling. The postpartum group is a really lovely lifeline for people who need more support, because the midwives' relationship to the families that they support, sometimes like that person doesn't have anybody else who they can check in with. And so to have the ability to say, if you need us more, come on Wednesday afternoon. We'll hold your baby, we'll weigh your baby, we'll make you some tea. And that really helps mental health as these moms and parents move into that journey.
Yeah, I was just about to say, can you tell me about the Donuts for Dads? I think I'm going to come for tea night. I think I'm going to be the specialist. That's what I'll come for. Yes. Can you tell us, you have Donuts for Dads, right? Or you still have Donuts for Dads, Kim?
Yeah, Donuts for Dads was just a quick story that Allegra and I, when we opened up the original Kindred Space LA, we had this great moms group, and we had community group and free Fridays, kinds of cool stuff we were doing. And Allegra's like, we really need something for the dads. And yeah, we really need somebody. And there was like these weird dads that were reaching out to us that didn't take children and wanted to be part of lead the dads group. And we're like, no, we're like, not them. And finally one day, Allegra said, we need somebody, Bobby. And Bobby happens to be my son-in-law, and he's just amazing. And so we reached out and asked him, and he said yes. And initially, before the pandemic, the dads were coming in person. I remember dads group where the dads came in person. First of all, the moms did not want dads to bring the babies. They were gatekeeping their babies. They were like, he can come, but he can't bring the baby. And I was like, why? Why can't he bring the baby? So they got through that. And when the first time the dads came, they not only were the dads dressed, they looked like they were going to church. And the babies were so well dressed, but I already knew that the moms did that. The moms dressed the babies and the dads dressed themselves. And I mean, they came with their strollers, and they just had so much pride walking into old KSLA with their babies. And so if you look back on our Instagram, I think we recently posted a throwback photo from that in-person group. And they're not rocket science, you know, but it felt and it feels revolutionary sometimes because these things aren't available. So anyway, it's become a virtual group, and it is still happening virtually every Saturday. Bobby now lives in Atlanta.
Thank you. Thank you.
Can I
We're
just
gonna
add really quickly?
Okay.
We all work in community, and so I send a lot of the partners and fathers from my group to their dad's group
Okay.
because they need it. So thank you.
We love that. We love that. Speaking of which, we're going to kind of slightly pivot in the conversation because part of how we got to this place in group prenatal care was because in AIM, when we first started in 2019, we had the option of the Perinatal Equity Initiative, which thankful to our current supervisor, Holly Mitchell, who was then senator. You can clap. You can clap. Yes, we clap. Thank you. Who pushed for the expansion of the BIH program, which was the Perinatal Equity Initiative. And so in LA County, we had our South LA AIM CAT Community Action Team and our Antelope Valley AIM Community Action Team. We had the opportunity to participate in what LA County would apply for. So what we applied for was group prenatal. Yes, give it up for group prenatal because it's our group prenatal, LA County's PEI funds that fund the CDU BMHCE's group prenatal. Additionally, we applied for fatherhood engagement. So we're excited. We're always excited to share about fatherhood engagement because our fatherhood engagement coordinator, Davion, has his Expectant Fathers series, so new dads can go through that. And then he also has Black Daddy Dialogues for fathers of Black children. So that's part of what this imperative and this work around AIM is, and on uplifting the work that you do so that we can talk now about what does sustainability look like, what has happened to education for midwives, access to education, also to care as we see the maternal care desert. So I'm gonna switch over here to Gabrielle Brown so she can talk about, one, I heard we had a conversation and Debbie was talking about the racism and implicit bias that folks experience. So you can talk about what you did with AB 2319 and now what California Black Women's Health Project, Black Women for Wellness, Western Law and Poverty is doing to uplift AB 55.
Right, so I can definitely talk about my work to address racism, discrimination, and implicit bias in healthcare. And so Black Women for Wellness Action Project, our 501c4, has really been innovative in sponsoring legislation in the state of California that seeks to improve the overall health status and the health outcomes of pregnant women and mothers in the state of California. And so speaking of Holly Mitchell, I would like to uplift Senate Bill 464, the California Dignity in Pregnancy and Childbirth Act, introduced by Holly Mitchell, which requires that perinatal providers in the state of California, they are required to take an implicit bias training every 2 years. This bill was passed into law at the beginning of 2020. No, that was right before when COVID hit. And so I imagine that there were many barriers and obstacles at the time, but nonetheless, this implicit bias training is a requirement for providers. We know in engaging with community, we hear stories about our mamas not being listened to, being discriminated against. And so it's important for us to hold those healthcare providers accountable in taking this implicit bias training. Part of my work is wanting to understand the compliance of policy that has been passed and understand the implementation of that. So with that being said, I established a partnership with our State Attorney General, Rob Bonta. The Department of Justice performed, I see some claps, thank you. Thank you. The Department of Justice performed an investigation into the compliance of implicit bias training throughout the state. And upon the initial query that the Department of Justice sent out, at least 80% of providers throughout the state of California were not compliant with taking their implicit bias training. Is this shocking? No. But nonetheless, it is still a requirement. And so with our effort to work to hold healthcare providers and institutions accountable, and continuing this partnership with Attorney General Rob Bonta, we introduced Assembly Bill 2319 titled Strengthening the California Dignity in Pregnancy and Childbirth Act. And essentially, this bill seeks to hold providers accountable. It seeks to ensure transparency in terms of all of the providers that a patient may come across that are required to take the implicit bias training. So thinking about folks at the front desk, checking in to their appointments, right? Thinking about nurses and physicians and just the entire scope of providers that our mamas would be coming into contact with, and ultimately clarity around the timeline, when folks are required to take the training, what those deadlines are. So I'm happy to say that that bill was passed into law last September. Thank you. And so now, institutions are required to report back to the Attorney General in regards to bias training compliance. I believe that begins in June of this year. And for those who are not compliant, those health institutions that are not compliant, they will now be hit with a fine. So really hitting them where it hurts and truly seeking that accountability. And so to pivot a bit into this current legislative cycle and another bill sponsored by Black Women for Wellness Action Project, and more, tied to the conversation today, I would like to uplift Assembly Bill 55, the Freedom to Birth Act. I have some fact sheets if anyone is interested and wants a bit more background and information. We'll have some at the Black Women for Wellness table. This bill was introduced by Assembly Member Mia Bonta.
Them Bontas are doing it, aren't they?
Right? Come on.
Okay.
The Bontas.
are doing it.
Yes. And so very, very grateful of that relationship with them. And so AB 55 ensures that maternal care for California families is more accessible by removing unnecessary requirements and needed for alternative birthing centers to become licensed by the state of California. I would like to make a connection and say that almost half of California births are paid for by Mo. And so in order for midwives and birthing centers to accept Medi-Cal patients, but to also bill Medi-Cal to be reimbursed at the rate that they deserve. Good rate, y'all. We heard today about all of the amazing services and support that they provide our mamas. So in order for them to receive that compensation that they deserve, these alternative birthing centers are required to be licensed by the state of California. And so we are seeing those obstacles and we're seeing those barriers. And as this bill moves through the legislative cycle, we are ultimately seeking to remove these unnecessary requirements so that, folks in our community can have access to these resources. Again, almost half of births in California are paid for by Medi-Cal. And so that really speaks to this need to have these services local within our community. Also want to speak to this trend of maternity ward closures. We saw most recently Centinela Hospital where April Valentine lost her life. That prompted an investigation. They were found to be negligent, fined, and instead of working to pay the fine and improve the quality of care that they provide to community members, they completely closed their maternity ward. And if you think about Inglewood, it's a densely populated area. I think the next closest maternity ward is in Torrance. And so trying to navigate from Inglewood to Torrance in LA traffic, and that's if you have a car, right? And so all of these factors compounding together really speaks to the need for us to have these amazing midwives servicing our community, but for these alternative birthing centers to have a clear and easy pathway to become licensed by the state of California so that they can receive the compensation that they deserve.
Well, thank you, protege. We're coming up with terms. I mean, yeah, because this one, she was like, well, this is Anyema and Lakeisha's bill. I really want to say you really gave us a good summary of that. And then you talked about removing that issue around the time requirement, the issue around addressing maternal care deserts. I know Kimberly and Allegra, you just opened up your location in AV. Is it open yet?
Yeah.
Okay.
It's pretty much open.
Okay.
The tubs are working.
The tubs are working.
The furniture is in.
So you'll be up in AV having a town hall on Friday, but I believe that part of, what was your rationale for going to Lancaster, Antelope Valley?
It was Dr. Desjardins' fault, actually. No, seriously, I just want to say something about the birth center licensure bill, and I certainly appreciate greatly the efforts to remove the onerous license requirements. I think that when Allegra and I were thinking about opening Kindred Space LA, it was top of mind that, yes, of course we're going to accept Medi-Cal. We knew that majority of our clients would likely be on Medi-Cal. But unfortunately, the other piece of the pie is reimbursement rates. And so many of the licensed birth centers who did go through the licensing process in California don't have a birth center anymore because they were taking insurance, but it wasn't enough to pay the bills because of these low reimbursement rates. I mean, and then some birth centers, some insurances that they were readily taking decided we're not going to pay for licensed midwives anymore. So they lost streams of income and had to close their doors. So oftentimes, it's not just can we be covered by insurance, it's can insurance pay us enough to keep our doors open. That is a huge issue that many organizations are working at. Midwifery Access California is a big stakeholder in working on reimbursement. But again, the reason why I say you can't fit traditional midwifery into the broken medical system template and kind of get the same results is because what are we seeing in the broken medical system? We're seeing very short appointments. We're seeing payments. We're seeing tons of people being seen in one day in order to pay the bill. So if Medi-Cal is going to reimburse a physician $20 for a prenatal visit, he ain't going to sit there for you with an hour. He's going to give you 5 minutes, if that, and he's going to see 40 to 60 patients a day. Where midwifery care is the complete antithesis of that, where we're spending, as we said, hours with our clients because that's the time that's needed. And we're not, it would be impossible for us to see 40 to 60 patients a day. Therefore, if Medi-Cal reimburses us for the, let's say in a practice of 4 midwives, we'll see maybe 15 people a day, and they reimburse us $20, you know, it's not going to keep the doors open. Midwives and physicians currently get the same Medi-Cal rate. There are ways to add in funding, such as facility fees and things of that nature, which kind of ties into licensing. But the hoops to jump through, you know, it doesn't really work. It doesn't work. So we not only have to fix licensure. If licensure is the thing that helps you get insurance, but insurance doesn't keep your doors open, then it's not, the math is not mathing. So we have to fix a lot of these systems. And at the same time, I can say that with the Midwifery Access California group that have been working as a stakeholder group of midwives and all different folks in the healthcare around California, we've been meeting for probably 5 years, and we still haven't gotten more reimbursement. That's 5, if we were waiting for it to get fixed, we would have missed out on taking care of all these people that we have taken care of in the last 5 years. You understand what I'm saying? So all these things have to kind of happen together, but at the same time, people are having babies every single day. You can't wait until it's fixed. until it's fixed. It may never get fixed. We're in a worse state now under our current administration. So I think that what is beautiful about midwifery and about as we stand on the shoulders of our ancestral midwives, as we of Biddy Mason, if no one knows who that is in this room, write it down and find out who Biddy Mason is. As we stand on their shoulders, what we glean from them is their tenacity, is the ways that they made a way out of no way, as the ways that they said, I'm gonna do it anyway. Even if the insurance isn't there, even if this isn't there, I'm going to do it because people need to be taken care of. And so that is still where we are today. And just wanted to point that out because it's not an easy fix.
And thank you for that. Thank you for pointing that out. But it's still good to know, how do you get compensated? Because I know, like for the doulas, when SB 65 was passed, it was a lot of work, and state groups came together. I think Dr. Priya even participated in that, to look at how to make, equitable pay for the doulas. So it sounds similarly like it needs to be a work group for equitable pay, because that was the issue. Like, nobody, we're not gonna eat. If this is all we get, we're not gonna eat. We're gonna bring the babies in, but we're gonna be hungry trying to do it or something. Are we gonna starve? Or it's we had to do this outdoors. How's it gonna happen? So talk about how you get paid.
Well, I just want to say your point.
Yes.
We can use what you all have done, what everyone here has done with getting doulas paid. We can do that to fund midwifery. We can follow that same model. So I totally agree with you.
Yeah, definitely. That's Kefri, Dr. Saida, Michelle. It was a lot of folks on that group. I had a capacity, but it worked, right? It's worked, and the doulas getting paid. Doulas in the room. How many doulas in the room? Doulas getting paid. Exactly. So you got a good number here. And I'm gonna let you answer that, and we're gonna answer any questions you have, because somebody's gonna tell us about Biddy Mason. I don't do it.
I wasn't, you wanted me to answer your question?
About how you're getting paid currently.
That's not what I was gonna answer.
Okay, go answer what you want to answer.
That's not the thought I had. So the thought I had in my head was that birth centers are a necessary option for sure, but most people don't want to have their babies out of the hospital, and that's okay. What is needed and what needs to be paid for is just midwifery care. Right. Midwifery care changes the statistics no matter where you give birth. So where the pay needs to be focused on is not, out of hospital birth.
Out of hospital birth.
But the care that you get to get you to a full-term pregnancy and a healthy baby. And that does not have to be at home or in a birth center. It can be in the hospital.
Okay, perfect. And I agree with you. That goes back to Janelle's point about what she recently heard from right? About how if midwifery was universal, then we would have a lot of lives saved, right? Even in this document, the fact sheet, so everybody make sure you get it, is that with freestanding births have demonstrated, and this is just about midwifery care, excellent outcomes for birthing people and infants, including reduced preterm and low birth rate babies, as you shared, decreased cesarean rates, increased breastfeeding rates, and save over $2,000 in cost savings to Medicaid for every mother and baby. I still want to go back so people understand how you get compensated currently.
Like old school, like you can bring me a chicken, some eggs from your garden. No, that's not true.
Or what are you doing to keep the doors open?
We have to use innovative methods. We have to think of out-of-the-box ways to get paid. So the reason why we're so grateful to Dr. Brandy and for the initiatives that brought that funding for group prenatal care, that helps sustain us. Right. Also, people with private insurance can use their private insurance, but they are often reimbursed after the care. So they have the ability to pay out of their pocket and then get some sort of reimbursement post care.
Yeah, it's still costly, and I think a lot of you are doing like
grants and things like that also can.
And allowing some type of scale of payment. Go ahead.
For the Wellbeing Alliance, where we provide prenatal care, postpartum care, mental health support, lactation support, It's private donors.
Mhm.
We're not funded by anybody
Yeah.
in this room, but we do get private donations and sliding scales, because people pay what they can.
Yeah.
But nobody's turned down, so if you can't pay, you still get care.
Ashe. Amen. Janelle, you were going to say something?
I was going to speak from a place of practice, home birth, midwife, how that pay schedule typically is, and that segues into the barriers for accessing midwifery, which is, Kimberly said, folks have to have the cash up front, essentially. So typically you enroll in care and you pay some sort of deposit, and then by 36 weeks pregnant, you need to pay the balance for your full care in cash. And if you have private insurance, specifically a PPO, not an HMO, but specifically a PPO, after the baby's born and all the care has been given, those clients would then go to their insurance and ask for, hey, can I have reimbursement for what I just paid for my midwifery care? And folks, depending on insurance, can get anywhere from 50, maybe 60% of what they paid back as reimbursement. But, you know, within Los Angeles metro area, home birth midwives are charging anywhere from $7,000 to $9,000, give or take. And so we'll have to have that in cash, and so many people don't, who would be really great candidates for that, for the care. So that's a major barrier. And even folks with insurance, with an HMO, still can't access midwifery care because it's not reimbursed by an HMO. So it's a major issue. And the care is worth it and more, but that's not the issue.
Right, and that's why I wanted to make sure we bring it up so folks know what are the challenges that you are facing, what are the challenges that families face, and maybe some of the fears they face in accessing midwifery care, but the outcomes can outweigh all of that, the value of being able to ensure that we reduce mortality and morbidity, especially no one really wants to talk about the long-term morbidity, short or long-term, that women face as a result. And there's 50 to 60 near preventable of those in our nation annually, as was reported by CDC. So previously, we'll see if we can get data. Oh, I digress. Are there questions? I wanted to, energize you, wake you back up, because we're going to feed you before you go. But does anybody have any questions for our panelists here? Lorna. Lorna's question was, could the family use supplemental insurance? Here, you can.
For midwifery care? For out of hospital birth? Most of the time, insurance does not cover. So we can give folks a super bill to see if they can get reimbursed for some of the money, but the barrier for us is that even though we do a very benefits and they say they cover X amount, when it comes time to pay, they do not.
It's kind of a bait and switch, because there are some insurance plans that'll say, oh yeah, we cover midwifery care. They need to be in our network, and then they won't have anyone in their network. And they're like, oh, well. So it's a broken part of the system for sure.
Hi there. Hi there. Mary Davis, clinical psychologist. I actually have quite a question that may be a bit controversial. So, if there are barriers to regular Western medicine, and we know that there are clear barriers, what can midwives do to address their own barrier of convincing what I would say patients that may not can afford your services? How do you convince a pregnant black mother on Medi-Cal to pay cash for your services, at the same time suggesting that their care in a hospital is worse but would be covered?
Can I say, first and foremost, we do no convincing.
Persuade.
The cornerstone of midwifery care is informed decision-making, informed consent, and so it's important that we restructure. The midwifery model of care versus the medical model of care centers the pregnant person to be the ultimate authority over their body. That's your body, that's your baby, you have autonomy. So I will do no convincing that you should birth with me or you should birth at a hospital. You actually need to come to that conclusion and then seek us out, because it's about responsibility, and that is something that the medical model is very happy to take away from people. That autonomy opens the medical model up to is litigation. Well, who's in charge of this care, right? I'm the doctor, I'm in charge of it, so now I have to work in a way to avoid litigation. But if the flip side of that is the midwifery model of care, where you are the authority, you have to make these decisions for your care. Some people are uncomfortable doing that and should not be outside of that model.
Only thing is that's true, and I'll take persuade off the table. That does not change the issue of payment.
Of payment, I'm sorry?
A payment.
So are you asking, is the question you're asking is how do we have a Black person, I'll say, come to our office and say they want midwifery care, they're on Medi-Cal, they don't have the funds to do that, and we're telling them that the care that they have that's covered is not care that's going to be good for them.
Correct.
So I think that's an individual question for each midwife, so I'll speak for myself. So I have my private practice, which is called Tribe Midwifery, and I have another practice called Wellbeing Alliance. The Wellbeing Alliance provides that care regardless of ability to pay, and it's for folks who are birthing specifically in the hospital. So you can come to us with a donation, you can come to us and pay something, or you can say, I have nothing, and we provide prenatal, postpartum, mental health, and lactation services. So that's for those folks birthing in the hospitals. For people who want to birth outside of the hospital, who come to my private practice, which is a home birth practice, sometimes it's bartering. Sometimes I do free births, because that is a valid question. I can't tell you, go someplace and be harmed,
But we can't automatically, I'm sorry. We can't automatically say that if they go to a hospital, they would be harmed.
No, that is
Cannot
correct.
say that.
That is correct.
Cannot say that.
That is correct, and that is not always the case. But what we can do is educate them on how to advocate for themselves in a space that could be harmful for them.
Yes.
Or in a space that the care that they get is not going to be good care. So a lot of folks come to and just get prenatal care just for that.
Yes, I just think it's irresponsible for anyone to say that Western medicine does not work and has good or bad outcomes. And I'm not saying that you are, but I'm saying that is something that's projected out of talking a lot about things that happen in Western medicine. The doctor who did the surgery on Kanye West's mother was a Black physician. So sometimes it's us. So all I'm saying is that I think it irritates me, to be honest.
It
irritates me a bit.
We can stick to the data.
Absolutely.
We can stick to the data, and the data shows worse outcomes when you compare the models of care. That's just statistics. That is what the numbers show us.
Love that.
And we're not saying that you need to, because to be honest, I've seen worse care from Black providers and Black people in a hospital setting than I've seen from other people.
Then we have to say that here too.
That is part of this conversation.
That is true.
It is the truth. Because what I found is that when providers in a hospital setting, nobody wants to be shamed by their peers. So if you're the one that's going to be on the out fringe, if you're going to be the one that's not doing what the protocol is for everyone else, you're going to be an outsider. Nobody wants to be an outsider. So for many reasons, Black providers are harmful to Black people.
Yes.
For sure.
Yes.
We're not denying that. But what we're saying is that if you come to midwifery care, if you get midwifery care, wherever you choose to birth, however you choose to birth, you can walk into that situation educated, understanding the challenges you can face and how to advocate for yourself under the circumstances.
I think that's great. I think, but if we're going to have sessions like this, both sides, I'm asking that both sides are given,
100%.
that both sides are actually discussed, because we're advocating people to have a choice in both areas.
Yeah.
That's all I'm saying.
It's really good you asked the question, because
Yes.
it is an important perspective.
It is.
And I will say that the people that feel like they're getting good support with their insurance and their provider, those are not the people that are coming to us. The people that are coming to us are the ones wanting something different.
Yes.
And because we are private businesses, we give what we can when we can, but we also, I think a part of being a midwife is understanding where we are not able to give anymore, right? I'm at the point where I'm like, I really can't work for free.
Yeah.
When I was starting out, I would, but now I really can't. But that doesn't mean that I don't care for that person that has this need that I'm not able to meet. And so that's where having community partnerships is really
Absolutely.
important. I will
Absolutely.
recommend people birth at Martin Luther King Community Hospital over
Absolutely.
another private hospital, because I believe, based on my experience in doing this work, that that is a safer location for them to use their Medi-Cal and have excellent
Yes.
care. So sometimes midwifery looks like that too.
Yes.
And that is free and available, I think, just out of the goodness of our, but like really that's a consultation. But if
Yes.
somebody can get to us, if they gets my number from their friend who I helped breastfeed 5 years
Yes.
ago, I will talk to that person, I will listen to what they're wanting, and I will help them find what they need on their available resources,
Yes.
and that is also midwifery care.
Thank you for clarifying.
Thank you. Thank you. Thank you both. And thank you for the question, Dr. Terry. I was going to say, yes, that is a conversation that we have had. There's a conversation that we do have, but today we're talking about honoring, celebrating, elevating midwifery, but we're also talking about from the midwives. So we definitely can denote that parking lot, that part of the conversation, so that we talk about the integration and the partnership and the relationship between midwives, between OB-GYNs, between hospitals, and what we're in doulas and all of that. And there have been those challenges that we face because there have been physicians that feel like there's no value, but 400 plus years of education, information, and experience show us a bit different. But nevertheless, and you highlight some key points. I think we have a physician that has worked with us that has shared many times that she's had experience providing care to Black and white patients, and when she tried to provide the same care that she gave to a white patient to a Black patient, then her peers said, no, you can't do that, and her boss said, you can't do that. So sometimes the experience is what it is that we're experiencing here in this nation. And so we just have to look at how we can factor in that and do the fix. I think we have one last question, and then I'm going to let my panelists close us out here, and then we're going to move through. Yes.
Hello, how are you all today? My name is Mary Meredith. I'm here today representing my research and consulting firm, Africana Dreaming. For the last 4 years, I've been working with a traditional midwife out of Boston, just helping her to do some research and understand better what's going on with her practice. In that research, I've had to look into legislation. I've gone all the way back to slavery to understand how midwifery was involved in healing and taking care of communities. I looked at legislation as it moved through the 1950s and how it changed into obstetrics and all of the things that I'm sure you guys are already familiar with. But I wanted to know how we as a community can assist you in the midwifery industry to really enforce the change in legislation. I have two nieces who were both pregnant 2 years ago. One of them was, I think, 29, and the other was 21. And the care that they received was drastically different, basically because of their age. The older was told that she was already at risk, at high risk, so they forced her into an early C-section where she almost lost her life giving, and she did it knowingly. She knew that she was at risk, but financially she could not afford the birthing experience that she wanted, so she had to go with what she could afford, whereas the other, she was just like, hey, I'm young, I'm doing it. She went in, birthed vaginally, had a great time, like, let's do it again. So how can we as community assist in making sure that the data does show that it is very dangerous to give birth at a hospital for Black or, brown women? Like it's very evident in the data. So how can we make it safer and also financially affordable for the communities who are at the highest risk of being killed in these spaces?
I'm not quite, I think your question is how do we fix this, really, in another.
Can be supported,
in
right?
a few minutes, I'll tell you. In a few short minutes, I'll tell you exactly how to do that. I think it's just a lot of factors. I just want to say this. We are so lucky to be here with these folks. Some of those folks that were sitting there that aren't sitting there anymore, but Adjoa, Priya Batra, Dr. Brandy, Dr. Melissa Franklin, and others, Raina Granberry, Jan, these folks who get it in this state, in this part of the state, are a huge reason that we are sitting up here, because we're being seen for the work that we all do in the community. And these folks support not only us, but other midwives in the community. Not every midwife in the community is sitting up here. Allegra and I were speaking with some folks today, and they were saying, what are some external factors that could make the job harder in this birth ecosystem? And they were saying, is there state issues? Is there issues with, and honestly, we feel that California and our partners here in Southern California and these folks right here are incredibly supportive of what we're doing. They are thinking outside the box with us about the ways in which we can elevate and provide midwifery care to our communities. So we're so lucky, and I have to say that even though it's not perfect, we're working to make things better. This is something that we're doing every day. Again, being innovative, thinking outside of the box. For instance, even providing group care is a very cost-effective solution, because the other piece of group care is you were able to see maybe 8 families at one time. So that cuts costs. And we're getting some funding from folks who see that as important and see the value of it, that allow us to extend that that cost savings to the clients. So, and so it's absolutely wonderful, and we have a lot more work to do. So that is huge. However, in many other states, who are trying to do the same things, they may not have supportive networks. They may not have supportive folks in their government that see this work as important. In some states, out-of-hospital midwifery isn't legal. So we are, a lot of time, before I lived in California, I thought that everybody, everything was great in maternal health care, and it's not, but it is, we are a step ahead in many ways, and I think if we continue to work together, we're gonna continue to find solutions for this issue. One last thing I wanna say is just that, we are not up here hating doctors. Does anybody up here hate a doctor? Debbie, you do? Okay. Dr. Friends?
She always like to be an outlier.
We have so many trusted doctors, nurses, certified nurse midwives that work in the hospital. Angela Sojobi at MLK Hospital is absolutely fantastic. She is also a professor at Fullerton. She brings her midwifery students to Kindred Space LA so that they don't carry any type of bias towards people who birth out of the hospital. She works in the hospital. There are physicians that we count as our friends, that we call on, and who understand as well that this system is broken. And they're working in it. And let's not talk about the many physicians who have left obstetrics, who have left medical service to go on to do other things, because they also understand that the system is horribly broken. And they want to do something different. They want to protect themselves and their own sanity. So, this is not a bunch of doctor bashing, except Debbie, hospital. No, I'm only kidding. It takes all of us to do this. And that's what it's about. We are being highlighted because we're often not. And so we're coming, Adjoa has given us an opportunity to come out of the shadows and connect how we support the public health of people. And that's it.
Yeah, I do want to just ask you all just to we'll go down and end here with, yes, my floater. Let's just finalize, and thank you for that, Kim. What can we do? What can LA County, what can everyone here do, as a young sister asked, to further support the work that you're doing? I think one of the things I want to make sure we understand is that we identify the gaps in services and resources. No question is a bad question. We just need to better understand and work together on it, because we want to ensure our main point is that folks thrive and survive. With AIM, we're focused on Black moms and babies, but then we also, all the work we've done is to support the larger community as well, all who want to give birth, who want to be pregnant, who want to be celebrated and supported, and who don't want to die in that process or have some lifelong issues. Some of us will never talk about it. We have women who have had 5, 6, 7, 8 miscarriages. We have who have had to deliver stillbirth. If we know for a fact there is something that works to improve and reduce, then let's uplift all of that while at the same time working to fix any type of broken systems where we can. So I'll let you all just maybe take 60, 90 seconds and 2 minutes and just come on down, starting with Allegra, back this way to me.
I think this has been really helpful. I love sitting with changers and people who I admire. I feel like, you know, having people have true choice with the available resources that they have into which location they would like to birth and what kind of way they'd like to receive care. I feel very inspired what the doula community has done, and I feel hopeful that something like that could also improve access to midwifery care, just like people have different avenues where they can access help or where benefits to have a doula, to actually have that for your care provider. And I think continuing, you know, to have conversations like this, a tough question. There's not that many tough questions that get asked to us, again, because the people who are seeking us out are the ones that want our care. So this was very exciting to really be able to have a strong conversation because we are true to this.
Thank you. Janelle.
Thank you. Yeah, gosh. Closing remarks. I think that coming from my background in public health and research and epidemiology, what I teach my students is around the importance of naming a thing. And just as Kimberly had said, when people say, I know it's traditional to go into the hospital and I might want to do something alternative. In the same regard, we have to name the model that is doing the harm and the model that is the solution. We have to name it, because if we don't name it, then we can't work to dismantle it. And so we have to name the medical model as the model that is largely harmful when it's misapplied. And, you know, as Kimberly had said, you know, who loves doctors? We need OB-GYNs. We need them, full stop. They're highly skilled, highly trained surgeons. They're specialists. I think what the issue is that it's a misapplication of the model when that's not the model that's necessary for a normal, healthy pregnancy. We're misapplying the model. We're utilizing a specialist where they're not needed. So I think that if we can approach this with that level of simplicity, then we can get further than you know, individual blaming. It's really a misapplication of specialty. With that said, I think that, you know, moving forward, the harm that was done to disparage and make illegal midwifery in this country was very deliberate. There was literal billboards and radio ads, and I really think public health needs to answer that today with the opposite. We need billboards. We need magazines, we need newspaper articles around the model of care that is shown to be most effective, especially for low-risk pregnancies. I think that we can't really, I shouldn't say can't, but I think that would be extremely helpful if the buy-in came also from top down, if you will, if you want to think of this as this river analogy. As midwives, we can't be the advocates and the midwives and run businesses and be the teachers and. We need buy-in on a major level, and I think that that can come from departments of public health and from institutions, not just saying that they value, but actually having an entire public health campaign that lasts years and years and years and years and years until we actually see the data change, because it's in the numbers right now.
Thank you, Ashe, to that. I see, I'm writing my notes. Your call to action. Tribe midwifery, Debbie.
I think that out-of-hospital birth is not the answer. Care is the answer, and the type of care you get. So I think taking our health, not just pregnancy and postpartum, but taking our health in general in our own hands, and understanding that the people you go to for care, you pay them to do a job for you. and they need to do that job well. And that you have the right to demand that on every level. A game changer. I think we feel intimidated when we walk into offices that we don't have the right to ask questions, that they know way more than us, and that if we don't agree, it feels intimidating to us. We do not have to be intimidated about what body. So I think, you know, you see people pay so much for weddings and gender reveals and all these. Put that type of effort in who your care provider is and what they bring to the table.
All right. All right. Well, that was a good old mic drop, because I'm like, yeah, you didn't pay $50,000 for the wedding. Is the marriage even worth it? Might not even last. You paid for the gender reveal. We didn't even have gender reveals. We were lucky if we got to be showered with some cake and a couple gifts. So now, you just said it. I mean, I've talked to people before in community that you might not need nails right now. You might not be able to get that front lace, that weave, that whatever, them braids. I mean, I could just talk about it. We talking, right? We talking what we to talk about. Because what is important, health is wealth, right? If I invested more in that than I did my health, I invested in a day, right? But my health is a lifetime. So
And you can't walk into office and give that to someone else. Like, you can't hand that to someone else and say, you're responsible for it, but I'm not.
Now that's critical. Now that makes sense. I'm scratching my head. That might be part of the Billboard campaign.
I want to say before we go to tap onto what Debbie said, we had there was an event this weekend called Crenshaw Mile that one of our clients actually created, and it was a beautiful event. So we got to have a little rest station for moms and parents and babies and dads, and to change diapers and feed babies. And several parents came up to me and said, wow, I really should have looked into you guys. But, you know, I had one mom come in, professional woman, her husband professional, and they said, you know, we bought a house, we bought this, and we just thought, we don't want to pay. It's just so much easier for us to just use our insurance and go to the hospital for our birth. But unfortunately, they didn't get the experience that they desired. Right. And that's just something that, from her mouth, it was a regret. So tagging on to what you're saying, it's sometimes a shifting of.
You can get that experience in the hospital as well, but you have to be proactive about your care.
Totally agree.
All right. Gabrielle, we got a last two.
Thank you so much. This has been so amazing, and I'm truly honored to be up here with you all. I always say I'm not a mother for my future self, and my future self will definitely have a midwife.
All right, future self. I love it. May have to be a little doula now, auntie doula. Okay.
Right. But in terms of next steps, stay connected. I'm open to connecting and collaborating. Stay connected with Black Women for Wellness and Black Women for Wellness Action Project. We have a table outside. Visit our website. Follow us on social media. Subscribe to our newsletters so that you can stay in touch with all of the initiatives and programming that we have upcoming. Speaking to that, I would like to highlight Black Maternal Health Week starts on Friday. Woo woo. And so with that being said, I'm hosting some dynamic events this year. This Friday, April 11th, I am hosting a Black Joy Guide launch event from 1 to 4 at the Kaiser Baldwin Hills Crenshaw. I have developed a resource guide titled the Black Joy Guide in partnership with Kaiser. And this guide really seeks to affirm Black mamas within our community, provide them information and connect birth workers like doulas and midwives, talking to them about finding the oasis in a food desert, you know, how to eat healthy during pregnancy and postpartum. And so I'm very, very excited to launch this dynamic resource guide this Friday, again, from 1 to 4 at Kaiser Baldwin Hills Crenshaw. Also, next Tuesday, April 15th, I am hosting our second annual Black Mamas Birthing Tour. And so I have to the party bus. I am actively recruiting Black pregnant mamas in the community, and I am taking them on a tour of various birthing spaces, institutions, and centers across LA County. Thank you. As my way to introduce them and ensure that they are aware of all of the amazing resources and providers within our county. And so Kindred Space LA is actually a stop on the tour. And so if you know anyone who is currently pregnant and wants to learn more about resources within LA County, please go ahead and see us at our table outside. We have a QR code for folks to register. So thank you.
Thank you, thank you.
This has been amazing, and I want to share what everyone else. Midwifery for me has been a lot about education and sharing with families, educating them and listening to them. And when families come with their kids ask questions, I love that even more. And I find that one of the ways that we can educate our community and population is maybe going to high schools and educating high school students, college students to understand what is a doula, what is a midwife, the choices, and to change the system. I also feel for physicians and the medical system they have to go through to just become physicians, because I know a lot of them get burned out just becoming residents. So it's like, how can we make it better for them? Because I know a lot of obstetricians want to be able to sit with their clients for a while, but they don't have the time to do that. So how can we change the system for them too? Because it's not fair. I want to see people, moms, Black moms, I want to see families thriving, but I want to see obstetricians and midwives not getting burned out. Because if we are getting burned out, people are not giving the care they families deserve, and families are not getting what they need. So what is the solution? We're still trying to find out. But
Thank
the
you.
work's happening, so.
Thank you. That, yes, give her a round of applause. You made a very, very valid point. Very, very valid point. We had some folks come to us, I want to say from Riley High School, which is for pregnant and parenting teens. I'm a former teen mom, so I know the need there. And so they're talking about the resources and the help and the services these teens are not getting. So it would be good even to connect. Black Women for Wellness has a Rites of Passage program, really be able to share with people their services and resources. So what I want to do is, wrapping up. Okay. So what we're going to do now is we're going to, thank you, Debrina. We're going to thank you all for this opportunity, for taking your time and sharing space, because we know babies don't come on the clock an hour. So I thank you for taking time to be with us. I want to thank you all, too, for being, give them a round of applause for their time and effort. We want to also thank our sponsor for today, which was California Healthcare Foundation. They have sponsored these events, and we're going to also continue these conversations. We'll have more of this going on. I want you to tap in and make sure you have information on AB 55. Also, go to California Healthcare Foundation. They have a lot of information about the California midwife workforce, so that if you don't have real knowledge and understanding, you can gain some more insight. I remember for me, some of what changed for me was I watched a documentary called Escape Fire, talked about our failing healthcare system, and it did talk about the time that doctors are only allowed to see clients and patients, and it really had me open up and have more understanding of what we are experiencing. But there was also some physicians that were working to change that model and system where, you know, they had to stop their private practice because they needed funds, so they went into a larger model healthcare plan or HMO. But what we really want to do is look at how overall, we talked about some of the issues, what's our fix and what's the next plan. I believe you all got a survey. Did everybody get a survey here? Okay, perfect. So what we want to do is make sure you completed the survey. We will have you all start to get up and get your food, because we want to make sure that everyone eats here. We're providing food today. Thank you to Black Women for Wellness for being our lead on this planning event for hosting and food and vendors and our honorariums. And then what I'm going to do, as you're getting your food, I want to make sure each vendor has an opportunity to come up and share the resources. So if you can quickly go around and get your food. But thank you. I know there's some in screen land. Thank you for joining us today on the live stream. I hope this has been a blessing to you as it has been to us. Follow us on Black Infants and Families LA.
We're on Instagram and on Facebook, and you'll see all of the upcoming events that we have going in LA County around for Black Maternal Health Week. And if you're in Antelope Valley, come see us on Friday from 3 to 5 at the MOA Center, the museum there, and we'll be doing this all over again. So again, thank you so much. And is there somebody who wants to come up and share? Anybody? Or just, you can go to the tables and talk to all of our folks here. Charles C. Black Maternal Health Center of Excellence, Mind, Body, Birth, the AIM Prevention Initiative. Janelle is here representing Jasiri Midwifery. Dr. Terry's at the back. The Amani Project, she'll talk to you about doula and menses. So let's do that. And thank you again. Thanks, everyone.